we present the technique of an arthroscopic double bone block cerclage for traumatic instability with bipolar glenoid bone loss. These are the author's disclosure. A double surgical team harvests 2 tricorticated iliac crest bone blocks, measuring roughly 2 by 1.5 by 1 centimeters and marked on their convex surface. They are then pre-drilled on the back table using a double 3 mm guide with 7 mm offset. The patient is now placed in the beach chair position and the standard anterior, anterolateral, posterior lateral and posterior portals are marked. The shoulder is scoped from posterior and an anterolateral cannula is placed. A rasp is used to mobilize the labrum and a traction stitch pulls it away from the anterior glenoid. At this stage, the glenoid is pre-drilled for future labrum repair using solid anchors. We now switch to an anterior lateral portal, which allows good visualization of the anterior glenoid, which is prepared with a burr to have a flat, bleedy surface. The attention is now brought to the posterior glenoid, which shows evident bone loss. A spinal needle is used to place the posterior lateral portal, and the posterior glenoid is prepared in the exact same fashion. A spinal needle is used to mark a new posterior portal which would be perfectly parallel to the glenoid surface. The portal is enlarged to the size of the bone graft and a finger can be used to ensure enough clearance to the posterior glenoid. An Arthrex 7 mm transglenoid guide is placed and the glenoid drilled with 2 3 mm cannulated drill bits. Care is taken not to over-drill into the subscapularis muscle. Nitinol wires are passed through the cannulated drills which are removed and used to shuttle 2 fiber link sutures through the glenoid tunnels. 2 fiber tape cerclages are first passed through the posterior bone graft. A wedge profile plate can be used to protect the graft from the future knots and tensiometer. The fiber tape cerclages are then shuttled anteriorly through the superior glenoid tunnel with the first fiber link. They are then passed through the anterior bone block and shuttled back posteriorly through the inferior glenoid tunnel with the second fiber link. They are finally passed through the posterior bone block and through the plate, completing the frame. This figure illustrates how the construct should look like at this stage. Back through an anterolateral view, the anterior graft is initially pulled down using the sutures. A clamp or a switching stick can be helpful to assure the positioning of the bone block. Posterior bone block and the plate are now pushed downward with the clamp and the switching stick helps to guide the alignment. The fiber tape cerclage are now cinched down and tensioned to 80 newtons with the tensiometer sitting on the plate. They are then secured with a few extra knots. The final stability of the construct is now tested. Through a posterior viewing portal, a standard Bankart repair with retention of the inferior glenohumeral ligament can now be carried out using the pre-drilled glenoid holes. This covers the anterior bone block and makes it thus extra-articular. A similar procedure can be carried out for the posterior labrum if sufficient soft tissue is available. A post-operative CT scan shows good positioning of the bone blocks and signs of healing at 3 months.